Shoulder dislocation in contact sport is not uncommon, and again we're seeing an increased number of shoulder dislocations, especially in the younger athlete, because of the higher level of recreational sport in the general population. The take-home message regarding shoulder dislocation is that the younger you are and you have a shoulder dislocation when the shoulder pops in and out, the more likely you're going to go on and have recurrent dislocations. There was one particular algorithm that was put forward to say that you can work out the reoccurrence rates following a primary shoulder reconstruction of looking at 100 minus your age, and that will equal the likelihood of a shoulder dislocation in the year or thereafter. Meaning that if you were 10 years of age, there's a likelihood that once you've dislocated, the year after you'll have a 90% chance of redislocating. If you were 50 years of age, as the age goes up, you're only 50% more likely of having a redislocation. But essentially, if you're under the age of 20 and you dislocate your shoulder, it's a fairly foregone conclusion that the year after that, if you're dislocated on the dominant side, as well as you go back to contact sport like rugby, you pretty much have an 70 to 80% chance of a redislocation. And the problem with redislocation or high redislocation rates when you talk to patients who have dislocated 2 or 3 times is that when the shoulder pops in and out, you also damage the end of the humerus to the cartilage, and down the track you can then have high levels of osteoarthritis, even in a non-weight bearing joint like the shoulder. But for me, one of the biggest concerns, if you have a younger athlete that's had a single episodic period of a shoulder dislocation and they've gone on to have, say, a second dislocation, the problem with it is that there also is an inherent danger if they keep dislocating their shoulder. What happens if that child's dived into a pool and dislocated their shoulder? They could drown because they can't swim out. What happens if they're on a flight from here to New York on an 18-hour flight and they dislocated their shoulder? They're not going to be able to get medical attention to relocate. So again, we don't want to see recurrent shoulder dislocations continue. In the initial part, when we see a younger athlete, we probably any sort of dislocation, you need to have a plain x-ray. It's a standard to make sure that A, it's gone back into place, but secondly, you don't have any bony bits of bone that have come on. We call these a Bankart lesion, because if they do, they need to have them operated on and put back on, and you get a much better result. So a plain x-ray is really important. To be honest with you, in the younger athlete, I'd still probably go through and do an MRI scan to check the extent of the labral detachment, which helps us determine whether they do need to go through and have surgery. And I'd have to say, in every shoulder dislocation case, as a physio, I'd like them to have an orthopedic opinion. And I think, and it doesn't mean to say we're going to rush them off and have surgery, but at least we've explored that as an area, and especially with the high dislocation rates in the future. Following a dislocation, they're put into a sling straight away, and there'd been a lot of recent evidence, or at least research, looking at the question of whether we should put them in a sling and hold them in different positions to help the labrum heal, or the capsule around it heal. There doesn't appear to be a lot of compelling information to say that that's particularly useful. Once it's torn, it's torn. Usually they come back into physio quite early in the piece, and we start them on a strengthening program to make the muscle stronger around the shoulder, stronger to hold the shoulders back, a different sort of form of exercises, and early strengthening intervention appears to be quite useful. The next sort of question that arises is, when should they go back and start playing sport again? If it's a non-contact sport position, and this is a general view, we probably say things like tennis on the dominant side, they probably wouldn't go back until at least 3 months down the track. Back to a contact sport on a dominant side, if they've now finished their rehabilitation conservatively, probably not before 4 or 5 months. You're going to give them a decent chance to reduce the likelihood of redislocation. And then finally, the question is, if you were then to go through and have surgery, the different types of surgery that are available. And there's 2 broad types. There's one where, a little bit like on this model, where they'll literally put a self-tapping screw and sew it back down, the labrum down. That's an arthroscopic labral repair. That's a simpler thing, operation done with little cameras, compared to a latter J reconstruction, which is they structurally move some bone and make it much more stable. And that's a common operation done especially in contact sport and rugby injuries, where we need to have a much more stable shoulder. And in brief, the interesting part when we compare between the two, the more complicated surgery, the advantage of that, you have many less dislocation more dislocations in the future, compared to the labral repair where it's probably not quite as stable. Interestingly, the rehabilitations for both are about the same. The difference is the complexity of the surgery. In our opinion, if you're going to err on the side of caution, you go for the more stabilising operation. We hope this has been useful.